Moving on to the second session for the day, let me introduce chairpersons, Dr. Vijitha Senaratne and Kirti Gunasekara. Over to you, sir.
Welcome back to the second session of this Asthma Day Symposium. Next, we will have the pleasure of getting Dr. Channa De Silva, who is a consultant pediatric pulmonologist at Lady J Hospital, Colombo, to speak to us on inhalers for pediatric asthma, why and how. Over to you, Channa.
Thank you, sir. Very good morning to you all. So within next 20 minutes, I am going to discuss about the use of inhalers in children, especially this is focusing on children. Why do we recommend inhalers for children? A little bit about the history of these introduction of these inhalers, and what are the science, especially the science behind this use of inhalers, and how do we use this science into the practical applications, and how do we educate the parents, children to use inhaler in a properly corrected way. So as you all know, the management, in the long-term management of asthma, we are try to achieve various goals. Obviously, we have to achieve symptom control, minimum, because especially when we are focusing on the children, we have to allow them to have their normal life with their physical activities, exercise, and have to allow them to have the normal growth of lung, pulmonary functions, and prevent exacerbations, one of the important things. So while achieving all these goals with the drugs, medicines, most important thing is, another thing is avoid or minimize side effects, because we know that most of the time the primary management, the most important drug is corticosteroids, as asthma is an inflammatory condition. So when we are using corticosteroids for long term, because asthma is a chronic disease, long-term disease, treatment is also long-term. So because of that, we have to give treatment for longer duration. So why it is important to use this inhaler techniques, or use these drugs as aerosols, or directly give it these drugs into the lungs, because we know that to prevent all these possible side effects, at least to minimize these side effects, we are using this, currently following these GINA guidelines with a control-based management. We assess the control, we adjust the treatment, and we review, and we'll continue with this with cycles, and we are using this stepwise management. So all these steps, as you all know, various inhale formulations, ICS formoterol, ICS SABA, ICS LABA, SABA, all these methods, main methods of management, short term as well as long term, contain these inhaler medicines. So the inhaler therapy, why it is important? It is simply, it's a topical application of medicines. Like we are putting eye drops into eye disease, so applying some cream to skin disease, or applying some gel or something to a joint disease. It's the same thing. We are directly giving the medicines at the to the site of the problem, especially directly activating or targeting the receptors. So it's a topical medicines when we are using these inhalers, and with that we can achieve the direct deposition of drugs in the receptor sites. So because of that, the advantage is we can use the very low dose of drugs. As you all know, we prescribe all the inhalers drugs in micrograms instead of milligrams we use for the other oral or other systemic drugs. And other important thing is when you are using especially for bronchodilators, the rapid onset of action is rapid, rather than giving it as oral route, going through the bloodstream and coming back to the where the problem is bronchioles or the bronchi or the airway. Here we can directly give the drug into the airway. Another thing is the systemic absorptions, because we are directly giving into the site of the problems and not targeting, or not the we do not use the bloodstream as the carrier. So because of that, the side effects also minimum. That is why it is very important to continue with these inhaler medications, so especially for the long-term management. This has been recognized early years. So this is one of the very good available, one of the very good evidence, the use of this directly giving this drug into the respiratory system. So this is almost 3,500 years ago, they used these drugs or the leaves and directly inhale to give into drugs into the respiratory systems. And later, there were many advances going to the revolution or this gradual evolution of this use of these inhaler medications. Various gadgets has been identified. Even sometimes, some era cigarettes has been used, just directly given into the respiratory systems as asthma cigarettes. So that is just again stressing the importance of giving these drugs directly into the lungs. And later in late 80s developed the first dry powder inhaler. So this is the first design, the scientific designs with the holes inside these two glass chambers to atomize and inhales. And later, so this was the aerohaler. Again, late 80s, one of the successful commercially available dry powder inhaler. And the system, these methods has been revolutionized in 1956 with the introduction of this metered dose inhalers. And finally, it became a commercial things like Medihalers. There were a lot of advertisements, paper articles in asthma. So at last, uniform dosage nebulization in asthma. So this was a Medihaler. And since then, there were a plethora of different types of inhaler medicines, inhaler devices with various different types of mechanisms, various types of drugs as well as the devices. So then, now as you know, very different types of these. There are different dry powder inhalers, MDIs are there, and the various mechanisms are there. So then, how can we select these? Out of these, especially in children, what is the best method to deliver the drugs into the respiratory system? So, whatever the method we are using, the most important thing is drug should reach the site of the problem. So, drug should reach the airway, especially the receptors where these drugs develop to act on these receptors. For that, whatever the method, whatever the drug, whatever the method or the medicine or the device we use, if it doesn't reach the lungs or the airway, then the actions obviously it won't happen properly as I expected. So because this is a little complex process, this drug deposition within the airway depend on the properties of this device, the type of aerosol generating device, size of the particles. Particle size is very important. I'll come back to within few minutes. Properties of the medications, dosage, and the disease severity, especially the disease, and the patient's factors, the breathing pattern of the patients, and the techniques, especially technique is important. We'll highlight this again and again throughout these presentations. And sometimes, especially like our country, third world countries, developing countries, patients' preferences and affordability, whatever the things, whatever sophisticated method we prescribe, if patients cannot afford. So all these things would be important because sometimes relative to these tablets and syrups, these devices, spacers, MDIs would be more costly. So sometimes even we prescribe, patients might not use these properly. So all these factors finally taken into account to achieve our primary goals of control of asthma in these patients. So these particles, drug particles, they are in an aerosol or the embedded in this air. So this aerosolized particle deposition is not a simple thing. I'll illustrate what is actually happening and how complex is that. So these particles are entering the air streams, and this deposition of these particles so depend on the size of the particles, and this important thing is the size. So it's not a simple measures like other things, because these the small particles embedded in the air, and these particles are not exactly the shape as spherical. So these are the irregular size particles, irregular shape particles. We just consider them as sphericals. So the mass median aerodynamic diameter is the most important. It's a complex term. And that particle density, airstream velocities, breathing frequency or the respiratory rate, all these things are important. All these things are finally leading to the shaping the final outcome or the lung deposition of these small particles. So this particle deposition depend on the three main mechanisms: the impaction, sedimentations, and diffusions. What is impaction? Impaction is when these particles embedded in this airstream, when this airstream hit on a surface, especially it changes angle. It's called this path length is equal to lateral displacement. So this lateral displacement, especially gradually, any of these particles has some inertial forces. So when this inertial forces reduce gradually, when the velocity is reduced, and then it's equals the other forces, especially the gravitational and the dragging forces, these particles embedded those stop their movement, or these particles deposit. So this is important thing is this, the UT, or the terminal velocities. Once these particles achieve this terminal velocity, these particles stop their movement, or the deposit in that place, especially when they hit on a surface. And this is mainly for larger particles. That is also depend on the air viscosity of this air, density of the air and these particles. And the other method is sedimentations. This is again the gravitational effects, especially its gravitational forces equals to the other dragging forces. So the inertia forces of these particles, then these particles get deposits, right? The final thing is a diffusion. Diffusion is a smallest particle, the small particles less than 1 mics act as the usual molecules, so they have this random motions, that is called the Brownian motions. With that, sometimes they diffuse into the tissues. Confusing? Yes, don't worry, me too. Don't worry about these science equations, these formulas. I just want to stress is, so you can see these diffusions, two formulas are there, and these two formula contain the Boltzmann constant, absolute temperature, air viscosity, particle diameter, all these things. So just want to stress is, it's not a simple phenomena like just drinking water. As we all know, when we drink water, all these, we assume these particles, water particles goes into the stomach, and that's also not a simple process. But this particle deposition in the lung is 100 times more complex process, as I just illustrates. Lot of physics is there. So how can we use these physics or these important factors or these techniques behind this into our clinical practice to improve the final outcome, which goals is to have the symptom control and prevent the exacerbations. So again, we go back to these infections. Very simple. It is the particles, larger particles, especially more than 5 micrometer particles, just directly hit on these airways, especially in the upper airways, and then they are deposits. And the sedimentation is due to the gravitational effects, the little smaller particles, 1 to 5 micrometers, especially those type of particles embedded in the airways with the gravitational effects. And the diffusion is very small particles, less than 1 micrometer. They just diffuse, and most of these particles again exhale, and usually they don't stay in the airway. So what is the clinical implications? We'll see little later. So why it is important? Because our respiratory system is not a simple tunnel. So there are a lot of bumps are there in the upper airway. So a lot of particles directly hit on these bumps, the nasal cavity, nose, and the large particles deposit in the nasal cavity. And then there's a almost acute angle, 90 angle at the pharynx. The direction of this airflow change. That time also significant amount of large particles deposit in the upper airway with the impaction. So these particles actually doesn't reach the lower airway, or it doesn't involve in the asthma management, and these are the particles which give rise to systemic side effects, and usually they swallowed and enter into the bloodstream through the stomach. As you know, then the lower airway is again complex things, and it's divided into 23 generations. So these small particles should reach all these generations to give rise to the our clinical whatever our outcome. So it's not a simple process again. As illustrated in this, larger particles stay in these pharyngeal regions, and the intermediate particles, especially 5 to 10 mics, these are actually important particles, deposit with the sedimentation. So we want to increase the sedimentations, we want to reduce these direct impactions in the large airways, and diffusions we cannot change usually. So the whatever this dry powder or the MDI, this plume contains particles of varying sizes as illustrated in this picture. So large particles tend to stay there. So we want to minimize this stay at the pharynx. We want to increase the particles retention in the lower airways. If we do not follow it properly, so this is the end results. Even though we just prescribe these inhalers to the patients, if patient doesn't use it with the proper techniques, So this is the end results. So the lung deposition may be low as 5% and significant amount finally end in the, or the lodge in the, especially the pharyngeal deposits, they solute and stomach and the systemic absorptions and give rise to the systemic side effects. Okay, so we want to minimize these systemic side effects. We want to increase the lung depositions. That's why it is very important to focus on this inhaler technique. So this graph summarize all the devices. What is the, so with the pressurized MDI alone, you can see this brown color, maroon color, that's the oropharyngeal deposition, significant oropharyngeal depositions. The blue color is the, oh, it's almost purple color. The lung depositions, you can see significant amount of particles retained in the pharynx, and the device deposition is this green color. So with the MDI the spacer, you can use, you see, but the most important thing, MDI with the proper spacer, with the electrostatic and non-static charges, lung deposition is significantly increased, with the pharyngeal deposition minimized, and so the unwanted fractions will give rise to the side effects stay in the spacer. So the side effects goes to the spacer. Who cares? Right. So that's why other important thing is with the DP inhaler, so significant proportions gain retain in the pharynx, and the lung deposition is against minimum. So in children, so various studies have shown that with the use of these technetium-99 label particles, with the use of a proper spacer device, the lung deposition is significantly increased, and this graph clearly illustrates. You can see without a spacer, significant proportions particles retain the pharynx and then the stomach, but with the spacer, these unwanted fractions which retain the pharynx now retain in the larger particles with the impaction in the spacer, but most importantly, the lung deposition is increased. So in children, maybe in adults also, in children, they don't have this proper hand-breath coordinations alone. Even with the proper hand-breath coordinations, significant proportions of particles retain in the other parts except the lungs. So no MDI alone for children, always you have to use a spacer. If a child is a small child, we can use with the face mask. If the child is older child, we can use with this. So in children, so that's why it's very important. So we have to always advise them about the proper inhaler techniques. We have to demonstrate it properly and always check with the regularly, because sometimes even whatever the instructions we gave, they might practice in a different way always. Every visit, ideally, we have to check the inhaler techniques. And there are various types of spacers. Actually, ideally, these are valve holding chambers. Now, almost all the spacers are valve holding chamber, which contain the one-way valve systems, and all of them have the anti-static properties. So what is the inhaler? How do we follow? So this is the technique of inhaler. I'm going a little fast because you know about this, and going giving the reasons for this. So we have to shake the inhaler, obviously, because it's contained the liquid form of inside the MDI. It's contained the liquid form with gases, pressurized gases inside, like our LP gas cylinder is a pressurized gas in the inside the liquid form. We have to shake it, because the propellant gas, it's about 80% of the content. Drug is about 20%, so even less than that. Always you have to connect it in the upright positions, and then there should be a very tight seal, and activate the MDI only once. That's the other important thing. Sometimes still people, if you want to go 4 puffs, they press 4 puffs together, but that significantly reduce the lung deposition. You can see with this nice study, with the 1 activation, 2 activations, 3 activations, even though we want to get the triple the lung deposition, actually it has reduced maybe in the 1/3. So various studies have shown that. So this is the conclusion of this study. Maximum aerosol bronchodilator form and MDI reserve was, so it's a summary. 2 rapid activations followed by a breath will give a significant accumulation of dose with some loss when compared to 2 single activations followed by inhalation. So we have to give one by one. If we press the 3 puffs together and take a single breath, almost 1/3 of the drug will be lost. So that's the other important thing. And we have to take slow breaths to allow the particles to deposit in the lungs or the airways. And if possible, small children, the single breath techniques can hold the breath for 5 to 7 seconds, again to increase the sedimentations, to improve the lung depositions. And to give actual next puff, better to wait about 30 seconds. Two, that is, again, there are some physical reasons, we don't have time to discuss that, and always shake again with each activations. So small children, we can use face mask with a spacer, and later we can use. So again, stressing, advise, demonstrate, check it regularly, and adherence is also important. So we have to always see whether this child is using it properly, correctly, with the proper adherence, because that's what the important thing. We may use this dose count is available to see whether he has taken it properly. And again, sometimes in other countries now they are using some electronic devices or even some applications to check they are using with the proper techniques. So in summary, inhale mode of the cornerstone of long-term management of asthma, not only children, for adults also. That's a form of topical therapy. So because of that, adverse effects are less. So aerosol particles deposition, that's the most important thing. That's a complex process. As I shown, a lot of physics is there, and the selection of the appropriate device depend on all these factors. And for children, the MDI plus a spacer is the best way. Sometimes we might use with the face mask, it's small children. So regular follow-up is important to achieve all these objectives of asthma control, or the goals of asthma control. Thank you very much.
Thank you, Dr. Chandra Silla, for that very comprehensive lecture. And now we know that asthma is a very heterogenic disease, and asthma in patient A is different to asthma in patient B. So therefore, treatment also has to be individualized. So now we have to speak on the heterogeneity of asthma syndrome. Dr. Niranjan Disanayake, President of the SLCP. Over to you, Niranjan.
Thank you very much, sir. And it is indeed an honor and a pleasure to present in front of you and Dr. Kirti Gunasekara, who are, I think, icons of respiratory medicine in Sri Lanka. And we are here because of the seniors like yourselves who have paved the pathway in respiratory medicine in Sri Lanka for us. So the heterogeneity of asthma syndrome, like people, diseases have different phases that they use for different circumstances. And the word heterogeneity means the being diverse in character and content. So like other diseases, some diseases like where you can have specific characteristics, but in asthma, in each step of asthma, you will understand the diversity of the disease, hence the combinations that can have are vast. Right. So it starts with the onset of asthma. The heterogeneity starts with the onset of asthma. There are identified subsets of asthma which are early onset asthma, and then we have the late onset asthmas. Right. So that is the onset difference. So some of them arise in the middle age, some probably in a little bit in the elderly population. But when you look at the symptoms also, we know that the hallmark of asthma symptoms is the wheezing, chest tightness, cough, and shortness of breath. But when you look at the patient presentations, sometimes there can be cough only, cough and wheezing. So there are combinations that the patient might have. And sometimes the patient might be asymptomatic at all, without any significant symptoms at all during the asthma patient. So the patients present very differently to us with variable symptoms. So symptoms shows heterogeneity. And then the number of exacerbations. Some people with specific features have increasing amount of exacerbations, while some people might not have exacerbations at all given a year. And then there are, even though we say the asthma is a completely reversible airway disease, there are certain types of asthma where you can have poor reversibility or no reversibility at all in the FEV1. So there are differences in that aspects. Now you can understand, I think, with these four features only, we can have a huge amount of combinations which might define an asthma patient, and that indicates heterogeneity. So to make matters a little bit complicated more, we have what we call the Th2 type of inflammation, where these patients will have increased eosinophilia in the blood. You can have increased eosinophilia in the sputum, increased eosinophilia in the bowel. If we do a pheno, the pheno will be high, or else the patient has a history of atopy, and this patient has skin prick sensitivity and allergic sensitivity, and that type of patients are called Th2 inflammation type of patients. And there are other patients who will not have these features, where you can have in the bile, you might be having no cells at all, or there might be a neutrophilic predominance in the bile when we analyze the cells. So now again another parameter comes in. So we can understand that there are huge amount of variabilities, huge amount of presentations that the asthma people can come. Hence it is very difficult to individualize treatment even if they want to. So one way of doing it is going for what we call a cluster. So this is the severe asthma research program where they are trying to, this is in the phase 3 now. It's a National Heart Lung Blood Institute initiated work. So they have tried to put these people with varying factors into clusters. So we have started with the FEV1, and then we have looked at the age, and then and with that they have identified basically 5 clusters. So when you look at cluster 1, there are mild atopic asthma. Then we have cluster 2, where you have a moderate atopic asthma. In cluster 3 there will be a late onset non-atopic asthma, and severe atopic asthma at cluster 4 and 5 have severe asthma with airflow limitations. So you might ask, why do we want to cluster? Because now these patients, individual patients, behave differently, and they have different responses to the treatment that they offer. Some are very responsive to corticosteroids, but some are very, very resistant to corticosteroids. So hence we should know which group that we have prescribing the correct drug. So we now are going into precision medicine because of this clustering. The phenotypes that are identified in GINA 2023 are the allergic asthma. So these are the GINA classifications. I was talking about the severe asthma research program classification. I think these GINA classifications are more practical. Allergic asthma is basically early onset asthma, where the disease the patients will have atopic features like allergic rhinitis, eczema, and these patients are very responsive to corticosteroids. Fortunately, majority of the patients belong to this group. And then we have what we call the non-allergic asthma, where the bile will show that there will be no eosinophilia, and this bile will show postgranulocytic or neutrophilic picture, and these patients are often resistant or lesser response to corticosteroid treatment. And then we have the adult onset asthma. Here we have patients presenting with features suggestive of asthma for the first time around 35 to 40 years, and they usually require a very high dose of corticosteroids to manage these patients. The important thing is, as Dr. Bhattadwarachi said, we have to think about occupational asthma in these patients. So these patients might not be having asthma at all, but when they are exposed to a sensitized agent during the occupation, they might develop asthma. So this is not adult onset asthma, this is occupational asthma. So we have to differentiate these two in these patients because the management is completely different. And then we have the airflow limitation with asthma. This is a severe asthma group where the airflow is already, the lungs are already remodeled. Interleukin 13 plays a major role in this asthma type, and these patients have severe prognostic implications when these are, some of the candidates are candidates for biologics as well. And then the typical group, a special group of patients where asthma with obesity, and they have very, very prominent respiratory symptoms. And then when we look at it, they have less amount of eosinophilic airway dysfunction. They have been shown to be responsive to leukotriene antagonists, and they are exacerbated by using theophylline. So there are treatment implications in this obesity and asthma group where the diet, the modification for the lifestyle has more impact than treatment at the moment of management. Right. So we have a huge amount of phenotypes, at least 5, and I think the GINA 5 are the best that we can go through because it's they are very relatable. And when we look at why, the next question is, why do they have this difference in expression? That is the most important thing. And then we have to go to the biology of asthma, where you have to look at the pathways that are causing these issues. So that is what we call endotyping. Endotyping is the underlying biologic sequence that results in a phenotype. Right? So this endotyping is very important in specifically the severe asthma group, so which consists about 3% of the population, right? So first, we know that when we're looking at the endotype in detail, we know that asthma is basically a airway dysfunction, smooth muscle airway dysfunction due to a chronic inflammation. This inflammation can be what we call a type 2 inflammation, where eosinophilic and IgE mediated inflammation will be there. And there are other types of inflammation. There will be neutrophilic inflammation, airway dysfunction without any significant inflammation, and we call it Th2 low asthma. And then we have the Th2 high asthma. So Th2 high asthma has a good response to corticosteroids in majority of the patient. That is the treatment implication that we have. So what do we mean by when we look at the Th2 type of asthma, the allergic asthma that we talked about, the onset at childhood, and where you have atopy, and then we have the exercise-induced bronchoconstriction. We don't call it anymore exercise-induced asthma. We call it exercise-induced bronchoconstriction, and there might be asthma coexisting. And then we have the late onset eosinophilic asthma coming down the spectrum, and then aspirin exacerbated respiratory disease. And then we have between the non-type 2 and the T2 type, we can have the very late onset of asthma, late middle age women coming with asthma. Then we have the non-type 2 respiratory type of asthma, prominently obesity associated asthma, because now we are getting a huge amount of obese people even in Sri Lanka. And then we have the totally non-inflammatory smooth muscle mediated postgranulotic in asthma. So these patients have different types of inflammation that is causing this airway smooth muscle dysfunction. So for a patient with smooth muscle mediated postgranulotic asthma, giving a steroid might be harmful because we are giving a totally inactive, an unnecessary drug causing unnecessary side effects to these patients. Right? And when we look further down to understand the pathophysiology and the endotype, the eosinophilic asthma, which is in your right, we have the eosinophils, Th2, mast cells, and innate lymphocyte cell 2, which is a very, very important marker which connects the eosinophilic pathway, Th2 pathway, with the viral infection pathway, which I will be going into detail in a little bit. So when you look at the cytokines, interleukin 4, 5, or 13 are the hallmarks of this asthmatic pathway. And then there are the cystine leukotrienes as well coming into the picture as hallmarks of these inflammatory pathways. So when we are doing an endotyping of the eosinophilic asthma or Th2 high asthma, I think for the postgraduate, the more important thing is interleukin 4, 5, 13 are the most important interleukins that we are dealing with. And then we have the epithelium. Now earlier we actually neglect the epithelium. We thought only about the smooth muscle. So the epithelium, when they are exposed to a certain substance, harmful substance, they secrete what we call alarmins. There are three main alarmins: interleukin 33, interleukin 25, and then we have thymic stromal lipoprotein. So these three are very, very important in mediating and activating innate lymphoid cells, and these innate lymphoid cells are secreting both neutrophilic inflammatory cytokines as well as eosinophilic mediated cytokines, and that might be a reason and a pathway that we have to target when we have childhood wheezing triggered by viruses. And then we have the neutrophilic inflammation, where we have the Th17 and the neutrophilic predominant one, and then we have the postgranulotic, the Th1. So we have basically Th2, Th17 and Th1 groups when we broadly divide into this. So I will not go into detail. But basically what does interleukin 4 do? Interleukin 4 mainly as class switches together with the action of interleukin 13 and interleukin 4 coming together, they class switch immunoglobulins from IgM to IgE, and this IgE goes and binds to mast cells, and when another allergen comes and gets attached to it, it degranulates, releasing a huge amount of histamines. And the interleukin 5 increases the eosinophil count by reducing the apoptosis and increasing the eosinophil output from the bone marrow. Right? And So one of the most important cytokines that we would like to talk about is interleukin 4, 5 and interleukin 13, because interleukin 13 is a specific biologic or interleukin that is very important in airway remodeling. That is the interleukin that we talked about fixed airway obstruction. When the patients have fixed airway obstruction with severe asthma, interleukin 13 might be playing an important pathway in these patients, right? And then this innate lymphoid cell 2, which is sensitive to interleukin 33, 25 and TSLP, which are called the alarmins, which secrete cytokines to stimulate the cells down regulation. And there are now blocking agents for TSLP as well, right? So why are we studying this in detail or thinking about in detail? Because it has treatment options which will be discussed in the next 2 lectures. I will be not going into details. So there are drugs that can block IgE. There are drugs that can block IL-4 and IL-13. There are drugs that can block interleukin 5 action. And now the newest kid in the block, there is a blocking of thymic stromal lymphoid protein, which upstream regulates the inflammatory process in certain epithelial damaging conditions, right? So hence, when we look at the symptoms of patients, we have the Th2 low asthma, where you will be having low eosinophils and low total IgE. We have the high IgE group with low eosinophil group. We have the low total IgE with high eosinophil group, and then we have the high eosinophilic with high IgE group, and which has treatment implications like this. So if the patient is having high IgE, low eosinophilics, omalizumab will be the drug of choice. And then like that, they are differentiating between the even from the Th2 type of phenotypes, they are further differentiating when we are thinking about treatment, which will be discussed by our Indian colleagues further, right? So now, other than that, there are basically smooth muscle airway dysfunction like that. So there are smooth muscle airway dysfunctions without any significant inflammation, simply because these venules, these nerve endings, secretes a significant amount of substances that are active against the smooth muscle. So they don't promote inflammation, but they promote airway dysfunction. So this is a non-inflammatory. So this is the possible underlying pathophysiology of patients who are having non-inflammatory prostaglandinolytic airway dysfunction in asthma, right? So when we look at the asthma phenotypes, we now divide into early onset, late onset, and the severity, and we have various types of cohorts or clusters that are there in this asthma group, and depending on this cohort which the patient has, I think that the treatment should be appropriately targeted. So a few words at the final regarding the obese related asthma, because there are new insights into obesity related asthma that we have to think about, because it is now a metabolic associated syndrome, right? So obesity, as we know, increases the asthma severity, it increases the asthma symptoms, and usually they have less well-controlled asthma and less favorable response to asthma therapy, unfortunately, as we highlighted previously, because their mechanism is rather different. They have low eosinophilic symptoms with they have low eosinophilic inflammation with very high load of symptomatology. So they are high in symptoms with low eosinophilic inflammation. But we have several obesity asthma phenotypes. So sometimes obesity per se might be exaggerating the asthma. Sometimes obesity might be causing the asthma. And sometimes uncontrolled asthma per se might worsen the obesity, because these patients don't do any physical activity as well. So there is a relationship between these three events. So why these obese patients are having increased shortness of breath, you can appreciate a typical female or male person with the excess amount of adiposity fat, where there will be a huge pressure to the thoracic wall, and when we have this thoracic wall pressure, it will affect the respiration, and the work of breathing will be significantly high, and these patients will have low end expiratory reserve volume, and there will be having a low residual volume in the lung. And when you have a low residual volume in the lung with increased amount of pressure, these airways are narrower when the patient starts to breathe the inspiration. So they have to have a higher workload in these patients, and when you have constriction happening recurrently, they have a pronosticity. They are prone to get more inflammation as well because of the mechanical stimulation that the patient has, right? And obviously, the patients have different type of inflammatory cytokines where TNF alpha, interleukin 8, interleukin 6, that will explain the patient why these patients are having neutrophilic asthma rather than any other thing. They have a highly sensitive monocyte coumatrite protein as well. But there are studies that say that there are no significant inflammatory pathways. So there is scope for improvement. So why do they behave differently? Because of the adipokines. Adipokines means the tissue cytokines that are there in the adipocyte tissue. Leptin is harmful. Adiponectin is good. So lectin basically have a low inflammation in the adipocyte, and by secreting interleukin 4 and interleukin 10, and then the leptin has an increase inflammatory adipokine, and then the patient will go into inflammation very quickly than in a person who is having adiponectin. So leptin is a harmful substance. Now this will be explained more here. When you have a lean body, you will have increasing amount of interleukin 10 stimulated by adiponectin, and when you are obese, stimulation by the leptin will have TNF alpha, interleukin 6 and interleukin 1 beta, which are neutrophilic humor attractants. So when you look at the obesity asthma paradigm, we have the biomarkers. The leptin will be high, adiponectin will be low, and the patient's interleukin 6 will be high. When we look at the lung function, FEV1 will be low, expiratory reserve volume will be low, and the peak expiratory flow rate will be low. Clinical features: risk of incidence asthma will be high, asthma severity will be high, quality of life will be low. And as I previously said, there are treatment implications. They respond a little bit more towards Montelukast because leukotriene antagonist has an effect on the lipid metabolism in the adipose tissue, and they have a negative reactivity towards theophylline. Theophylline increases the severity. And as a final slide, heterogeneity of asthma is not a simple thing. It helps us to guide the treatment according to the patient, where we'll be doing a precision-guided treatment, but it will depend on multiple factors: genes, the expression of genes which are controlled by certain factors, airway histology, lung function, and the patient as well as a whole. So there are various variabilities coming into the heterogeneity of asthma. Some we know, some we don't know, and some we will be discovering in future. Thank you very much for your kind listening.
Thank you, Niranjan, for that difficult area topic, which was handled with a lot of clarity. And we will have the questions at the end of the session. I think next we have to go on to the next speaker, but it will be an online lecture which will be held. So can we go on now?
Good evening. On behalf of Indian Society, I would like to thank Sri Lanka College of Pulmonologists for inviting me for this lecture. And the topic for today is biologics in asthma. Without wasting much time, I will go to the biologics, and my talk has been made simplified by the previous speakers. So you all know that in case of severe asthma, we all have the new medications in the armamentarium for use. But before jumping on to that kind of medications, we should also know certain facts, that are we dealing with asthma alone, or are we dealing with any other differential diagnosis like a foreign body, COPD, airway tumor, or a vocal cord dysfunction, etc. So differential diagnosis has to be excluded. Ensure compliance to the inhalers and supervise and ensure correct inhaler technique. As you all know, inappropriate inhaler technique is the most common cause of asthma exacerbations. Address the comorbidities like other upper airway diseases, GERDs, thyroid diseases, obstructive sleep apneas, etc. And also administer proper quantity of medicines in appropriate dose like inhaled corticosteroids, LABA combination, LAMA, LTRAs, and sustained release theophylline as per the GINA guidelines. So if all these measures, including the environmental control, fails, And then we may need to think about stepping up of asthma treatment to from step 4 to step 5 kind of treatment. So before initiating the biologicals, we also need to educate the patient about the treatment options available, the duration of the treatment, the cost of the treatment, because you all know that it is a very costly treatment as far as the patients who are especially giving from out of the pocket kind of treatment, and alternate options, if any, are available, and also ensure that the adherence to the appropriate medications are there. Threshold for considering MAP, mainly because of the problem with the oral corticosteroids. If you see the previous GINA guidelines, maybe 10 years back, except for omalizumab, your regimen was for obstructive oral corticosteroids for step 5 asthma, along with other standard line of treatment. So you all know that the current OCS use has got problems like osteoporosis, hypertension, obesity, type 2 diabetes mellitus, cataracts, fractures, GI side effects, HP axis problems, and all those things. So if you have got 4 or more short bursts of OCS per year, it is sufficient to induce sustained steroid adverse effects for those individuals. So you also need to identify the treatable phenotype traits, which has been discussed already, and prospective for biological treatment. In cases of atopic asthma, we prefer anti-IgE treatment. In cases of eosinophilic asthma, we prefer anti-IL-5 treatment, and there is an entity called neutrophilic asthma where none of the this thing mostly works, but we may need to go for the bronchial thermoplasties or long-term macrolide administration, etc. And there is an overlap of atopic as well as eosinophilic asthma in our clinical practice. So tools for phenotyping already discussed. The clinical history, blood parameters like the IgE and absolute eosinophil count are the major things, and as well as the induced sputum eosinophils. You also do the specific allergy testing to enroll the patients for biologics. So there are certain caveats for the monitoring of IgE and blood eosinophils, like falsely high values can be there and falsely low values can be there. Falsely high values can there be in our Asian setup. Indian setup, definitely it is there because of the helminthic infestations. The genetic makeup is such that we do have a bit higher level of eosinophil count. And falsely low values can also be there because of isolated IgE deficiencies, frequent systemic steroid therapy. So always need to consider testing the eosinophil count repeatedly, especially when the patient is not on systemic corticosteroid or when the steroid dose is as low as possible, because most of the patients may be initiated on low dose systemic corticosteroid for the management of severe asthma exacerbations. So the choice of agents for severe asthma phenotypes will be the available drugs are omalizumab, which has been available for the past 20 years, mepolizumab, which is an anti-IL-5 agent, risdiplam is also an anti-IL-5 agent, benralizumab is an anti-IL-5 receptor alpha antagonist, and dupilumab is an IL-4 receptor antagonist, and tezepelumab is a newly added molecule which is US FDA approved. Out of which omalizumab, mepolizumab, and benralizumab is available for clinical use in Indian setup. Dupilumab is undergoing trial, and risdiplam is also not available for clinical use in our setup. So basically, we'll be discussing more about omalizumab, mepoli, and benralizumab. So just a general comments. There are no head-to-head trial between these individual agents to compare the efficacy of one above the another. Although we have come across few studies, but it is not fully approved kind of thing as of now. All molecules are effective for the management of severe asthma. Each subsequently marketed agent especially appears more efficacious than the earlier ones. Like omalizumab has been there for past 20 years. We use it for IgE mediated atopic asthma, and later on mepoli came, and then menrali. Add-on advantages are there for each molecule, which I will be coming in my later slides. Each one has got unique advantages and disadvantages. First molecule that we are going to discuss is omalizumab. It is an anti-IgE monoclonal antibody. It is an IgG1 kappa human framework containing 5% murin antibody complementarity determining regions. And it binds to circulating free IgE, and it prevents the IgE binding to high and low affinity receptors. And it is a very safe drug with very minimal risk of anaphylaxis, which without much long-term side effects, because it has been available for clinical use for past many years, and long-term safety profile has also been approved for those patients. This particular drug, and it's a small biologically inert omalizumab Ig complexes are formed after the administration of Ig. It's a non-complement fixing antibody. This is a way by which it is acting. It binds to circulating Ig and reduces the mast cell bound Ig and decreases the Ig receptor numbers as well. This is a pathway for asthma trigger, where when there is allergic mediators comes to the mast cells which contains these receptors, the free Ig receptors. If it is there, then the allergic reaction happens, and inflammation and inflammatory mediators got released, and asthma exacerbation happens. But when the omalizumab binds to this free IgE upon this mast cells and basophils, the allergens are less likely to bind to this IgE, and anti-IgE molecule definitely improves the outcome. So there is no free IgE left to bind with the allergic mediators. That is the mechanism of action of omalizumab. So with this, it reduces the asthma exacerbation and improves the asthma symptom scores, improves the upper airway symptoms in case of coexistent allergic rhinitis. Is very well used in allergic rhinitis as well, and improves the quality of life, has steroid sparing effect, and reduces the rescue medication like the need for oral corticosteroids and ED visits. And it has also been approved for the use in idiopathic urticarias as well. So there are certain trials which favors the use of omalizumab. These are all in the early 2000s, which happened, and which eventually made omalizumab available for clinical use. These are the Innovate, ITOPA, Solar trials, and the Alto trials. All these trials basically shows the exacerbation rate reduction, and reduction in the inhaled corticosteroid use also has been approved in one study. And also Alto study noted the side effect profile, and which has been proven safe for clinical use for long-term use as well. Reduction in exacerbation rate has also been seen in this study as compared to the standard line of treatment. There is obvious improvement in atopic Ig mediated asthma. And all this pooled analysis shows that when in omalizumab, there is a statistically significant reduction in annual exacerbation rate as compared to the standard line of treatment. So the omalizumab advantages are it has got a very largest body of experience and decent efficacy on exacerbation reduction, effective in other atopic states as I've already mentioned, and good data in pediatric population as well. It's been approved for more than 6 years of age. Indian biosimilars are available because the original molecule is not available now, and but we do have the biosimilars which actually decrease the cost of therapy to some extent. Disadvantages: it's modest effect only in steroid sparing and lung function improvement. No much improvement, and no immediate improvement will be seen in these patients. And broad exclusion criteria has been there for use. That is the main problem that we are facing with the usage of omalizumab. When we check the total Ig levels, it may be more than 2,000 or 3,000 or 4,000 in those patients, and it may be difficult to for us to enroll the patients into omalizumab, because there is no specific dose which is there, because the maximum dose that we can give is 600 milligram fortnightly. So the ceiling of 1,500 of Ig level is the best that we can use as a cutoff point. Even the 750 is where we can actually give adequate dose at an appropriate weight based level for those individuals. So that is one of the major problem. The exclusion goes very high, exclusion rate goes very high, even though the patient has got exacerbations. Reconstitution is also labor intensive, and dose and frequency calculation is also cumbersome because of you have to calculate with the weight and the Ig levels. Coming to the second molecule which is available since last 5 to 7 years in India is mepolizumab, and it is an anti-IL-5, as I have already mentioned. It causes a blockage of interleukin-5 and eventually decreases the growth, differentiation, mobilization, and recruitment of eosinophils, and eventually decreases the airway inflammation because it decreases the cytotoxic mediator formation. Okay, so eventually reduces the exacerbation. It is actually US FDA approved it for more than 6 years of age, but in India it is only approved for adult use as of now. Indication and dosing: it is indicated as an add-on treatment for severe refractory eosinophilic asthma, and dosing is for adults 100 milligram every 4 weeks. Is intended for long-term treatment, and need for continued therapy should be considered at least on an annual basis as determined by the physician assessment. Once you initiate these kind of biologics, you also have to see for the stoppage of medicines, as well as reduction of stoppage of OCS, reduction of ICS levels, and also to see if this particular molecule is actually improving the FEV1 and also the clinical symptoms, and also try to wean off the medicines as well. And also the need for the drug also needs to be assessed, especially once you stop the medicines because of obvious reasons. In all practical purposes, though we don't have any endpoint for all these biologics, we at some point of time in practical purpose have to will be stopping these medicines because of obvious monetary issues as well. So that is the reason. At that point of time, we also need to have a extra vigil on the patient's clinical condition. Asthma control questionnaire has to be properly maintained, and also the PFTs has to be regularly taken. Patient selection criteria: the patients who are on therapy with high dose inhaled corticosteroids and additional maintenance treatment, and in the verge of oral corticosteroids, and exacerbation history, 2 or more exacerbations in the past 1 year, and dependency on systemic corticosteroids. Patients who are on steroids also can be enrolled. Blood eosinophil count more than 150 at the initiation of the treatment, or more than 300 in the last one year is chosen as a selection criteria for mepolizumab. So the various trials have given us a data of positive outcomes for mepolizumab, like the DREAM, MENSA, MUSCA, and SIRIUS trials have given a very good reduction in exacerbation rate and asthma control, and improvement in FEV1 in patients who are enrolled on mepolizumab. And as compared to omalizumab, the improvement that we see is drastic, especially those patients who are having very high eosinophil count. Higher the eosinophil count, better the response be with all these kind of IL-5 and IL-5 receptor alpha antagonists. So reduces the exacerbation recurring reduction admission by 69%, and clinically significant exacerbation reduction by 64%. So the graph is the same improvement in clinical symptoms as well as control in almost 75% of the patients. Osmo study is one thing where mepolizumab is used for omalizumab failed cases, and it is also proven effective in omalizumab proven cases, especially if the selection criteria is met. Even in high Ig mediated atopic patients as well, if the eosinophil count is high, we can enroll into mepolizumab. The advantages are decent real world experience. Now we are pretty much experienced with the use of mepolizumab. We at our center is doing one study, and it's an ongoing study about the patient satisfaction score and usage of mepolizumab with an auto injector. It is given by an auto injector, so it is very easy for use. Actually, the patient can use it at home as well. And definitely there is a powerful reduction in exacerbation, effective and approved for HES and EGPA as well. EGPA, the dose is, if the dose is 100 milligram monthly for asthma, EGPA the dose is 300 milligram on a monthly basis, 4 weekly basis. Success is there in failed cases of anti-IgE treatment. And disadvantages are failures are uncommon, but it is reported, but otherwise no much kind of this thing. Also, you have to ensure that the absolute eosinophil count is not spuriously high, and helminthic infections and all such other cases of raised eosinophil has to be excluded before enrolling to MAPOLI. Benralizumab is also a drug which is available for clinical use. It directly binds to IL-5 receptor alpha, preventing IL-5 from binding to eosinophils, and it recruits the natural killer cells as well. So the reduction in eosinophil count, peripheral eosinophilia, is absolute and very fast and long sustained for benralizumab. It is much more stronger effect than mepolizumab as far as control of the reduction of eosinophil count is concerned. In this picture, I have given this dupilumab as well. It is an IL-4 receptor alpha antagonist, and blocks the IL-4 as well as IL-13 signaling as well. Coming back to benralizumab, the real world studies of benralizumab, like the BPAP data and all the previous data has shown significant amount of reduction of exacerbation even for atopic as well as non-atopic patients of asthma. And exacerbation reduction is to the tune of around 80% in patients who are enrolled to this particular study data. It also reduced the exacerbations and OCS use and improved the daily scores, and regardless of atopic status and in real world setting. I've already informed about this 85% reduction in exacerbation rate. It can also, there is a study where it is used in mepolizumab failed cases. The data is equivocal. Unique aspects are improvement in all aspects of asthma care, fastest response, and it is given as a dose of 30 milligram. First 3 doses are monthly, and then every 8 weeks is the dose. So the number of injections that the patient receives is less, and highest magnitude of benefits as well. It is undergoing trial for this EGPA as well, and if the dose for EGPA is considered, it is the same dose as that of asthma. So it is actually non-inferior. The studies have proven that it is non-inferior to mepolizumab and has got some kind of superior effect as far as the dosing pattern is concerned, and sustainability of eosinophil count reduction in severe cases of asthma as well as EGPA. Coming to just a few slides on tezepelumab, it is a monoclonal antibody that blocks thymic stromal lymphopoietin, and which is released by the epithelial cells in response to pro-inflammatory stimuli. It is TSLP is related to both T2 cytokine expression and disease severity in asthma, and the halt in the inflammatory cascade is much higher up than the IL-5, IL-4, and IL-13. So it can be used in any kind of even TH2 type or non-TH2 type of asthma to some quite a good effect. It has been US FDA approved, but not available for clinical. Remission, definitely remission is one thing that is is practically right nowadays everyone is looking into remission of asthma, like the remission of other immunological conditions like rheumatoid arthritis. Real world studies have been there, like for Mepoli, Benrali, Dupilumab, and Tezepelumab, and best remission rates has been achieved with Mepoli as well as Benralizumab, and to some extent Dupilumab. But there are a few more studies which are awaiting as far as this Tezepelumab and Dupilumab is concerned. So we are actually thinking about remission of diseases, reduction of OCS and cessation of OCS, and also reducing the dose of inhaled corticosteroids for those particular patients. That is just a thought process. You should not be overzealously decreasing the dose of ICS in these subset of individuals in clinical practice. But yeah, we will get much more evidence in coming weeks or months or in near future. So at the annual review, the remission means if the asthma control questionnaire score is less than 1.5 and there is no OCS for disease control or no maintenance OCS for disease control, and FEV1 is above the lower limit of normal or no more than 100 ml less than baseline pre-biologics FEV1. This is how the remission is defined. No remission can happen if the patient is having an earlier onset of asthma and if there is delay in initiation of biologics and greater exacerbation burden and resultant repeated exposure of OCS in the past. Seen in female sex, obesity, comorbid depressions, anxiety, frequent exacerbations, etc. So these depression and anxiety may be contributing to the lack of compliance to drugs as well. So you should always, to conclude, you should always remember biologics play a major role in the management of severe asthma if nothing else is working, and you should not be hesitating to start the biologics early into the disease, but waiting unnecessarily will cause airway remodeling and reversibility may not be that much achieved. Remission induction is an exciting prospect, and we should consider that part also. Ensure that the ICS dose is adherent before and after initiation of biologics. When the patient starts on a costly therapy, then the patient may become less adherent to the ICS dose. So you should be educating the patient thoroughly and continuously on each visit. Ensure that the environment triggers are all minimized exposures. Keep an open mind to switch the biologics as well and to stop the biologics. With this, I would like to conclude my talk, and I'll be happy to take any questions. Thanks.
Very much, Dr. Paramesh, for that detailed talk on biologics and the use in severe asthma. I think we will have to proceed with the next lecture as well. The next asthma is severe asthma practical workshop by Dr. Indranil Halder, Associate Professor and Head of Department of Pulmonary Medicine, College of Medicine in Kalyani, West Bengal, University of Health Sciences. So over to you, Dr. Indranil.
In the onset, I should thank the Sri Lankan College of Pulmonologists for working with us and giving us the opportunity to be associated with them. And I'll be discussing on the severe asthma workup. So to start with, asthma is a chronic inflammatory disease of the airway. There is airway hyperresponsiveness, and this is what is the pathophysiology. The patient will present clinically with variable airflow obstruction within the lungs. There is recurrent episodes of wheezing, breathlessness, chest tightness, and/or coughing. The variable airflow obstruction will be reversible either spontaneously or with appropriate treatment. Now, there are different terminologies. For example, what is poorly controlled asthma, what is difficult asthma, what is severe asthma. So we have to know what is controlled asthma. Well controlled is fewer symptoms, no nighttime symptoms, no overuse of the short-acting beta agonist, no restriction of physical activities, no absentees due to asthma, no exacerbations. Poorly controlled is daytime symptoms more than 3 days per week, nighttime symptoms more than 1 night per week, more than 3 doses of a short-acting beta-2 agonist per week, restricted physical activity, and any exacerbation over the previous month. Now coming to difficult asthma. Difficult to treat asthma is asthma that is uncontrolled despite prescribed medium to high dose of inhaled corticosteroid plus a second controller, that is a long-acting beta agonist, or with maintenance oral corticosteroids, or that require high dose treatment to maintain good symptom control and reduce the risk of exacerbation. It does not mean a difficult patient. Asthma may appear to be difficult to treat because of modifiable factors such as the incorrect inhaler technique, poor adherence, smoking, comorbidities, or because the diagnosis may be not correct. Now, a subset of difficult to treat asthma is the severe asthma. It is uncontrolled despite adherence with the maximum optimized dose of the ICS LABA treatment and management of the contributory factor, or that worsens when the high dose of treatment is decreased. It is sometimes called severe refractory asthma since it is defined by being relatively refractory to high dose of the inhaled therapy. But with the advent of biological therapies, which we will discuss, the word refractory is no longer appropriate now. One caveat is that asthma is not classified as severe if it is markedly improved when the contributing factors such as the technique or the adherence are addressed. So basically, we are puzzled with some of the terminologies: uncontrolled, difficult to treat, treatment resistant, refractory, brittle, because of a lack of precise definition and use of loose ambiguous terminology. But again, what we have to know is when it comes to the GINA step 4 and 5 treatment, it contributes about 24% of the asthma. Of them, 17% is difficult to treat asthma, that is poor symptom control. But of them, only 3.7% or so of the GINA step 4 and 5, which has poor symptom control plus good adherence and inhaler technique, contributes to the severe asthma. So how do we identify the difficult asthma in our clinical practice? Watch patient use the inhaler, discuss adherence, the barriers, compare inhaler technique with a device-specific checklist, correct the error, recheck every visit, have an empathetic discussion, confirm the diagnosis. If the lung function normal during syndrome, consider halving the ICS, remove potential risk factor, assess and manage comorbidity, consider treatment step up. The step up treatment may use shared decision making and the balance potential benefit and the risk. Now, before that, after removing the potential risk factor, assess comorbidity, these are the patients who are difficult to treat. But if there is still asthma is uncontrolled after 3 to 6 months on the step 4 treatment, then it may be treatment resistance or severe asthma, and we should be referring to an expert advice, and the patient may be referred earlier if asthma symptoms are severe or if there is a doubt in the diagnosis. So basically, this is the way that we should be approaching a patient of severe asthma, a confirming of the diagnosis in the first step, looking after the comorbidities of asthma, the aggravating factors for asthma, whether the patient is getting adequate treatment, the technique and the compliance, and ultimately phenotyping and the biomarkers in the severe asthma. I will start with one of my case long back in December 16 before the COVID. He was 68 years male, engineer, smoker of 2.5 packs a year. He used to have paroxysmal dyspnea on exertion, which was grade 2-3, cough, die with occasional minimum expectoration, wheezing episodes in the winter, and it was for the last 30 years. And he could find out the triggers, which was strong smell and dust. And November, December were the affected months. April, June also better in between, where he didn't require any medication. But the symptom increased for the last 3 months. He is persistent wheezing. The dyspnea has increased from the grade 2 to grade 3 and 4. Sputum, whitish, sometimes yellowish, on and off. So history of allergic reactions to aminophylline derivatives. He has allergic rhinitis, hypertension since 8 years and on amlodipine. He was on salmeterol fluticasone, 250 micrograms, 2 puffs twice daily. He was on off on montelukast levocetirizine, SOS prednisolone of his own, a few courses of antibiotic. 2015, 4 months total treatment duration. 2016, all year round, he was on treatment. Examination was not that significant. And let us see and place this patient on the different steps that I have told. So first is I have to confirm the diagnosis. So you have the armamentarium of investigations. You have the routine blood checkup, the chest X-ray to rule out other confirmed other diagnosis. The most important is the spirometry, which, for example, when we did this patient routine, there was a dyslipidemia, but the rest was normal. The chest X-ray was essentially normal. And if you see the spirometry, the FEV1 by FVC ratio was less than 70, and the FEV1 was 1.67, that is 70% of what is predicted, and it was so moderate obstruction in that way. The sputum examination, no pathological growth was found. CT scan showed fibrotic area in the right middle lobe and the posterior segment of the right lower lobe, mild traction bronchiectasis, maybe sequelae to some old infection. Rest, it was normal. So again, going back to our the statement on asthma diagnosis and the definition, it's a heterogeneous disease, usually characterized by chronic airflow limitations, has to be defined a history of respiratory symptoms, which include a cough, wheeze, shortness of breath, chest tightness. The symptoms vary over time and in intensity together with variable expiratory airflow limitation. And it is not a static disease. The wheezing, the dyspnea, the cough, the rescue medication, the FEV1, all varies with time from being poorly controlled to good control. And we should remember some of the differentials which are misdiagnosed. For example, vocal cord dysfunction, dysfunctional breathing or hyperventilation, that is a panic attack, bronchiolitis obliterans. The cardiac cause, the congestive heart failure is sometimes mimicked like asthma, bronchiectasis, hypersensitive pneumonitis, eosinophilic syndrome, pulmonary emboli. And in this part of this world, tuberculosis has to be always ruled out, upper airway obstructions. So some of the differentials which we have to keep in our mind and has to be checked and rechecked if we are really confirming our diagnosis. Now coming to the step 2, where comorbidities of asthma are to be looked for. And in fact, if you see, a lot of comorbidities are there, which include these differentials with COPD, because we have to know that our patient was a smoker. So there are rhinitis, allergic, non-allergic, polypoid, hyperventilations or glottic dysfunctions, psychopathologicals, nicotine dependency, respiratory infections, and other obesity, OSA, GERD are one of the most common comorbidities with asthma, and it has to be taken care. So coming to the aggravating factors, so associated overlap with asthma, allergic bronchopulmonary aspergillosis, if there is a suggestion or suspicion, fungal sensitization, Church-Strauss syndrome, ongoing exposure to allergic triggers. Now to find out whether the treatment is adequate or not for the symptoms, and we have fortunate to have the GINA guidelines with us, where we can place the patient according to this step. For example, the patient has to be increased on a high dose of inhaled corticosteroid and LABA. The other controller options with tiotropium or a high dose with a leukotriene or theophylline may be chosen for in these patients. So for our patient, weight reduction, physical exercise, chest physiotherapy, breathing exercise, and the dose was increased 500 micrograms twice daily. Montelukast levocetirizine, prednisolone given in tapering dose. Theophylline could not be used because of the allergic reactions. So 3 admission in June 2017 with acute exacerbations, treated with antibiotics, and the current medications which include ICS LABA-LAMA, that is the triple therapy, SOS short-acting, the combination of short-acting SAMA and the SABA. Prednisolone was given again in the short course. And if you see, the ACT was 12 and the patient needs rescue medication daily. The echocardiography shows good left ventricular functions and show the cardiac condition was normal. And if you compare the spirometry from December 16 to June 17, you can see there there is the FVC is decreased, the FEV1 is decreased from the previous. But what is important, we can see some sort of reversibility here. The ACT has increased from 13 to just 14 and not significant in that way. So coming to the step 5, where the technique and compliance is very important. Whatever device he is using has to be appropriate, and the errors has to be checked and rechecked. The compliance related issue has to be taken care. For example, in PMDI, coordination, slow, deep inspiration and breath holding is important. But what we usually prefer is giving a spacer with the PMDI. DPI, full expiration and then breath hold after the preparation is important. And what is and also to be seen is there are two types of technique problems. One may be intentional and one may be because of the pseudo adherence. Intentional because of the motivational belief preferences, and pseudo adherence may be because of the resources, the capacities, and some of the practical barriers which are to be looked and taken care, and it should be checked and rechecked regularly. So here also the all steps checked with the patient, the compliance, the technique, the comorbidity is assessed, but still the patient is symptomatic. What is the next step forward? So let us see, that is the in assessment of severe asthma, phenotyping and biomarkers are to be done. So coming to what is the phenotype and what is the endotype. So phenotypes are a set of observable characteristics of an individual resulting from the interaction of a genotype with the environment, which for examples may be atopic or non-atopic, obesity or not. An endotype is a subset of the condition which is defined by distinct functional or pathobiological mechanism. For example, whether the subject is eosinophilic or non-eosinophilic, Th2 high or low. So again, the guidelines suggest that the patient with severe asthma may benefit from phenotype-guided therapy, and it may be early onset, late onset, symptoms, more less exacerbation phenotype, FEV1 less or more. The most important may be the Th2 inflammation or not, or less Th2 inflammation. And there is overlap between each of them, childhood onset phenotype to late onset phenotype, and each has an overlap on all of them. So what is to be known is allergic asthma is the most prominent phenotype of severe asthma, and targeted therapies for allergic asthma holds a greater promise of such patient. And if you see some of the studies, allergic asthma is the most prominent endotype in severe asthma. For example, in few of studies, it has ranged from 50 to 90%. Coming to phenotyping and biomarkers. Of the clinical phenotypes, I have already discussed allergic, non-allergic, asthma with fixed airflow obstruction, asthma with obesity, late onset asthma, asthma with frequent severe exacerbation, corticosteroid dependent or not. Biomarkers on the basis of the airflow inflammation, and often on the basis of biomarkers, the serum Ig, the blood, or the less often done is sputum eosinophil, the exhale breath nitric oxide, or the serum periostin. So additional investigation for phenotyping, what we have seen that Ig is 704 in this patient. We have done blood rest, Aspergillus fumigatus, Candida albicans, and house dust mite was positive. Cockroach was also strongly positive. The pheno was 45, sputum cytology. In that way, doing the sputum eosinophil was not available in a center. So what are the tests for allergy? We have a magnitude of test, either in vivo or in vitro. The in vivo may include the skin prick test, intradermal patch challenge test. And in vivo, we have the total blood Ig or specific serum specific Ig. Now comes what to choose. Practically of this, the skin prick test is the gold standard, or a specific IgE may be done in vitro if we are doing. The inflammatory phenotypes may be allergic eosinophilic asthma or non-allergic eosinophilic asthma, or the non-Th2 dependent, which may be the neutrophilic asthma. Not going to the details, but if you are using pheno and sputum eosinophil in asthma, so just go for whether there is symptoms suggesting airway disease. We have to assess for possible eosinophilic airway inflammation. If there is a raised pheno more than 25 parts per billion, or there is sputum eosinophilia, we can start with steroid. If there is an adequate response, we can continue. If the response is not adequate, if there is a normal or low pheno or sputum eosinophil, we have to see, or if there is a raised sputum eosinophil, we have to see. If there is a raised sputum eosinophil, taking treatment correctly, then we can increase the dose and consider referral. If there is a normal or low pheno, identify and treat the aggravating factors, symptomatic therapy, and then follow up the patients. So choosing appropriate candidates for appropriate intervention, severe allergic asthma, serum IgE, FeNO, atopy status by the skin prick test or the RAST, severe eosinophilic asthma, blood or sputum eosinophil, FeNO, severe asthma with bronchial wall thickening, the CT scan may be of helpful, HRCT, severe asthma with bronchitic symptoms, sputum neutrophil, smoking, biomass exposure, the spirometry may be helpful, and the FEV1 may be a surrogate marker. Patients having recurrent infective exacerbation, clinical marker, fungal sensitization, we can work up for an ABPA. So coming to the treatment and biomarkers. So on the one hand, if we see a patient of low IgE versus high IgE, so a patient who is having low blood eosinophils and low IgE, that means we can post the patient for a bronchial thermoplasty, we can suggest weight loss or give macrolides. Patients having a high serum IgE and low blood eosinophil may be atopic, and these are the patients who we can put on omalizumab. Having high blood eosinophil with a low IgE, these are the non-atopic asthma, anti-leukotriene 5 or other anti-Th2 drugs may be tried. Patients who are having high serum IgE and high blood eosinophil, and these are the atopic asthma with eosinophilia, anti-IL-5 and other anti-Th2 may be given, or omalizumab may also be tried. So this is from one of my chapter which I have seen written in patients with severe asthma diagnosis. To make this simple, features of atopy with sensitization to one or more of the aeroallergen plus IgE 300 to 700, we can go for omalizumab. High peripheral blood eosinophil count with history of exacerbation, mepolizumab, benralizumab may be tried. High FeNO, that is more than 25 parts per billion plus history of exacerbation, dupilumab. History of exacerbation plus atopy or high eosinophil, then tezolizumab. This patient optimized available therapy on step 5 GINA. We started omalizumab, 3 vials every 15 days since 2027. As per the dosing schedule, the body weight has to be seen, the total IgE has to be seen, and the patient remained better after that. And we are continuing with the medication. Patient is on ongoing treatment. There are 2 infective exacerbations which were treated, and we plan to comply with the therapy for at least 1 year, though there is no specific time duration for which we should be continuing. Now coming to one of the important phenotype of asthma, the small airway disease in OADs. So there are a lot of studies which suggest, then lastly the Atlantis studies has shown that about 60 to 50 to 70% of patients of asthma have small airway disease, and 30 to 40% in children also. And we have to recognize the small airway disease. And if we see in the small airways in asthmatics, we can see that there is luminal occlusion, mucosal inflammation, smooth muscle hypertrophy, thickening airway walls. And it is to be known that asthma also involves the small airway not only in patients with severe asthma, but also in milder disease, in nocturnal asthma, and in exercise-induced asthma and allergic asthma. So, whereas asthma was thought initially to be a large airway disease, now that it also involves the small airway to a huge extent is to be kept in mind. And there are different ways of assessing the small airways, but the simplest way may be by an oscillometry, either an FOT or an iOS, but spirometry to some extent can give an FEF 2575, or if you have the luxury of doing a plethysmography, or the imaging may give to some extent the idea of your small airway assessment. And what is important, if there is a small airway involvement, the drugs, the particle size, for example, we can see from this picture that the larger particles that are there cannot reach the place of the small airways. Only the beclomethasone, the HFA molecule, and that too can be deposited, that too can only be deposited in the small airways. So coming to the treatment approach in asthma starting from 2000 to 2025, whereas in 2000, we thought of one size fit all, that is no patient selection in treatment. Then came the clinical phenotype targeted treatment with clinical function in inflammation biomarker. Then came the molecular phenotype targeted treatment, that is the molecular biomarkers. And then it's the time from precise medicine therapy, precision medicine, that is predictive biomarkers of response to be found out and treated accordingly. So I should conclude that difficult or severe asthma patient needs systematic evaluation in steps. First is confirmation of the diagnosis, the biomarkers, which includes Ig, pheno, peripheral, or sputum eosinophil. The adherence, compliance is to be appropriate, and optimized medication is to be done. We have to look for associated conditions. For example, the allergic rhinitis, GERD, OSA, the hormonal and psychological factors. We have to assess the comorbidities, the phenotyping, clinically, and the phenotyping, whether it is Th2 or non-Th2 is very important. Individualized approach in severe asthma, and we should always keep in mind the role of the small airways, because we have specific drug for that, the ultrafine particle steroids, which reaches the target place, the small airways. So thank you. And now we can go on to have some question answers.